Good morning. Good morning, all. Thank you for the kind introduction. So, from the first trimester, on a beautiful Friday like this, we are moving on to the second trimester now. Basically, first trimester is dedicated to the risk calculation for the aneuploidy, and then second trimester, we look at the structures. This was the old thought. However, first trimester, anomaly screening, that is, structural abnormality screening is possible in the first trimester itself, apart from the aneuploidy screening. However, by and large for the India, a single 18 to 20 week scan, and now with MTP Act moving on to 24, 18 to 24 week scan gives entire information which is required. So as you all understand, ultrasonography constitutes the cornerstone of modern obstetric care. All those consultants assembled here, if any one of you say that, no, I can manage the pregnancy without ultrasound, you may raise the hand. Thank you, nobody. So without ultrasonography, we cannot manage pregnancy, even though it is supposed to be low risk. However, scanning requires multitasking, where we need to have the medical knowledge, technical dexterity, and you also should know how to navigate various probes. The objective of the ultrasound scan is to provide accurate diagnostic information for the delivery of the optimized antenatal care with the best possible outcome for the mother and fetus. As you understand, as you go through this information given on this guideline, actually the other goals, the detection of the congenital malformations becomes the other goals mentioned in this. That means apart from the structural abnormalities, there is so much of information is given by this second trimester anomaly scan. The standard of care and then guideline we all use is updated ISUOC guideline, which is released in 2022, that is last year. Gestational age cutoff, as I have said, from 18 to 24 weeks pregnancy. The earlier scan, they date better. For those who miss the CRL scan, dating is always by the crown rump length. But if a scan is missed for some reason in the first trimester, still the earlier scan around 18 weeks gives a better idea, and later scans, we can see the fetus better. More than 24 weeks of gestation, though we evaluate the fetus for those who have missed the scan, the PNDT Act comes to help us take any decision serious, if at all. What is important while scanning is that know your machine. There is no point in having Apple iPhone in your hand and you do not know what apps you have, and then you don't know how to do that. Well, ultrasound image depends upon understanding of the basic functionality of the ultrasound. Can I just ask how many of you actually scan? Okay. Oh my, not your colleagues though. Yeah, thanks very much. So most of the things I understand that you depend upon the scan report generated by the colleagues. So this is the basic knobology that we call to optimize the image. That is just like our selfies, each image we click for the fetus has to give a lot of information which is pertinent. The equipment, the modern equipment available has all these features. One important question many of the couples ask, especially when they come for the monitoring like Dopplers on a weekly basis for high-risk fetuses, is that, is ultrasound safe? I was told that my grandma says that too many scans are not too good. Then we go this by principle called ALARA, that is as low as reasonably achievable. That means exposure to the ultrasonography is very safe. In fact, we say that in high-risk pregnancies, if we do not have a particular scan done, then we will be at the loss. And therefore, we can assure the couple that ultrasound is absolutely safe. This is the 7-step successful approach for a detailed scan, which gives the entire information. As you understand, it starts from the history, because whenever you have a mother, you categorize or triage her into low risk or high risk. And depending upon the risk factors the mother has in the terms of previous history or current pregnancy, then the approach towards the baby inside changes. For example, if it is a diabetic pregnancy, we will be looking forward to look some of the markers. At the same time, if a mother has a Down syndrome, then the approach to the present pregnancy is different. Same way, a cardiac case previously, the approach to the current fetus is different. Like that, we will go through so many checklists as we see. The survey is very important, which also includes situs. Situs means a place for everything and everything in its place. So in the first initial orientation itself, we will get how the fetus lies in the uterus, and then what is the left side and what is the right side. And also we check whether the right side organs are on the right side of the fetus and left side ones on the left side. Then as we move on, as I said, biometry constitutes one of the important things. In this, the prerequisite for the gestational age determination is CRL. Even if you have not done that, please review previous images and see, date the pregnancy properly, because mid-trimester anomaly scan, one of the important things is that we have to give the biometry properly. This is the guideline we use at Fernandez Hospital. Up to CRL of 84 millimeters, we date the pregnancy by crown rump length, and later, if at all, by the biometry, and go according to this ACOG guidelines, compare the biometry with the previous gestational age, and then see whether it is matching or not, whether the dating is done in the first pregnancy, first trimester scan itself or not. The biparatal diameter and head circumference constitutes important factors for the biometry. So the midline facts you have to appreciate, and then thalami on either side. That is why it is also called as transthalamic plane. And there has to be a symmetric appearance of both the cerebral hemispheres. In this particular plane, we should not be visualizing the cerebellum, but what is important is cavum septum pellucidum has to be seen, so also the insula. Coming to the abdominal circumference, we have to make sure that in the plane, the spine is to one of the sides, and then the stomach is seen, and intrahepatic portion of the umbilical vein is seen properly, as well as there has to be adrenal, and there should not be any kidney. One rib is seen in this particular plane because the plane may go through 11th or 12th rib. So these are all the pitfalls whenever we take abdominal circumference. If the spine is anterior, we get a lot of shadowing and so on and so forth. Therefore, the proper planes includes spine onto one of the sides. Femur length constitutes another important biometric parameter. And then when we take the femur length, we have to see that the whole of the femur and the diaphysis is seen properly. And then epiphysis, we should not be including in when measuring the femur length. The anomaly scan essentially goes through three planes, that is mid-sagittal, axial, and coronal. Most of the times in the mid-trimester anomaly scan, we depend a lot upon the axial planes, that is transverse planes of the fetus. So the standard planes of imaging institutes, first the head. This is transverse section of the fetal head, where you can appreciate the cranium integrity, and then the suture lines we can appreciate. Midline facts, which is interrupted by the cavum septum pellucidum, and then frontal horns are seen. In the same area, we also can appreciate the lateral ventricle. So in the head and brain, when you see the lateral ventricle, we have to see that the lateral ventricle measurement is less than 10 millimeters, which is normal. And then a specific characteristic feature, and then landmarks are given where to measure this ventricle. As you see here, parieto-occipital sulcus is seen, and the lateral ventricle measurement is taken here, and the measurement is always less than 10 millimeters, irrespective of the gestational age. More than 10 millimeters is called as the ventriculomegaly. And then later we move on to the cerebellum. You can see here, as you slide from the upper to lower, that is distal part, you can appreciate the dumbbell-shaped cerebellum, and then worm is in between. So this is also a very important plane. Transcerebellar diameter corresponds to the period of gestation up to 24 weeks. As we move axially, you can see both the eyes, the orbits, and then lens. As we move down, you can appreciate maxilla as well as mandible, tongue as well in this particular section. So abnormalities like hypotelorism, hypertelorism can be appreciated. The sagittal view of the face constitute another important thing, and as described by the first speaker, nasal bone up to 20 weeks of gestation can be a marker appreciated in this second trimester as well. So these are the coronal face, and then eye orbits, and then nasal bone, and premaxillary triangle, which are important in the face. Coming to the cardiac imaging, interestingly, cardiac imaging actually starts from the abdomen. So we have to, as I have said, make sure that the situs is read properly, and then heart, once the situs is determined, the heart and the stomach are on the same side. As you appreciate in the systematic analysis of the heart, we go through the size, position, structure, and function of the heart. And this is the four-chamber view of the heart, exactly taken where the mediastinum is in the middle. You can appreciate the heart, and then symmetric lungs on either side. Also, do not forget to see the descending thoracic aorta just in front of the spine, and then appreciate internal features of the heart, that is the left atrium, left ventricle, right ventricle, and right atrium, and moderated band in the right ventricle as well. So many landmarks and abnormalities can be picked up in this particular view itself. And other views include the LVOT, where you can see origin of the ascending aorta from the left ventricle, including the color you can appreciate. Also the RVOT, that is right ventricular outflow tract, that is pulmonary artery, main pulmonary trunk, which bifurcates actually. This bifurcation is appreciated in the transverse view of the thorax. So there is what is important parameter or important plane, which is called as three-vessel view. We call it as line dot dot, where you can appreciate the pulmonary artery, the aorta in the middle, and then superior vena cava. If you put color, this actually forms a V shape. This is called as three-vessel tracheal view. It gives a lot of information about the conotruncal abnormalities. So this is a single clip sweep, which takes you to the four-chamber view, to the LVOT, RVOT, as well as the three-vessel tracheal view, where the cardiac abnormalities, both in the four-chamber view as well as the conotruncal abnormalities, can be picked up very well. So this picture summarizes the cardiac planes. As we move down, we go into the abdomen, which can be studied in three levels. The stomach level at the umbilical vein, and measurement of the abdominal circumference is taken. The two important anechoic structures which have to be documented always from 14 weeks of gestation are the fetal bladder and then fetal stomach. The portal vein can be appreciated as well, and the gallbladder. We can appreciate the portal vein by putting the color. So kidneys constitute other important thing. And you can see in this particular plane image, which is showing the cord insertion. This has to be documented in all cases of anomaly scan we do from almost 14 weeks of pregnancy. Even in the first trimester, this constitutes an important standard of plane, because the abdominal wall defects like gastrochesis or omphalocele can be picked up in this particular plane. As we move, as I have said, insertion of the umbilical cord can be seen. The two arteries go and then swap around the bladder. This is how we document the bladder, definitely in the mid-trimester scan onwards. You can also appreciate, as I have said, two anechoic structures which are mandatorily to be seen in the fetal abdomen. Then we move on to the spine imaging. One or two longitudinal views demonstrating the whole spine are very important, and tapering of the spine has to be documented in all the scan. Also, a longitudinal sweep in the transverse section of the fetal spine from the cervical region to the sacrum is very, very important in the mid-trimester scan to pick up major abnormalities like neural tube defects as well as sacral agenesis. Limb imaging, coming to the longitudinal view, in a single sweep you can see the proximal, mid, and then distal part of the limb. And then ankle, documentation of the ankle joint is very important, where we can actually exclude the talipes as well. If the baby comes and says hi to you, then majority of the abnormalities can be excluded, especially the trisomy 18. So in the upper limbs also, we have to document three segments, that is proximal, mid, and then the distal, which includes the hand as well. So this picture gives an idea about all the standard planes for the limbs. Genitalia with the PNDT Act, we do not document it anyway, nor we see as well. So apart from the fetal imaging, it is also important that we document the placental localization in the mid-trimester scan onwards. And if at all any doubt is there, then we have to go ahead and do the transvaginal scan, because os placenta distance of more than 20 millimeters is normal. If the os placenta distance is less than 20 millimeters, it is called as low-lying placenta. And in this particular women requires a rescan at 32 weeks of pregnancy, whether to see that placental false migration has happened or not. Because in 95% of the cases, in the later part of the pregnancy, we can see that the os placenta distance will be more than 20 millimeters, and then it is no more called as low-lying placenta when we reviewed her. ISUOG has come out with all these standard planes into what is called as 20+2 planes lecture, and then standard of imaging. It includes one overview sweep and one sweep. So it includes a spine, as I have explained to you, longitudinal head and body in the orientation, and then sagittal spine with the skin covering, coronal complete spine and coronal section of the body. And the head planes include 4 to 6, which include transventricular plane, transthalamic plane, transcerebellar planes. And in the thorax, 7 to 10 planes, which includes lungs with the four-chamber view, left ventricular outflow tract, right ventricular outflow tract, and three-vessel tracheal view. See, these are the standards of imaging, and then whenever you ask for a scan and then the fetal medicine consultant gives you the report, you can go through these images and then say that whether it is done properly or not. When it comes to the abdomen, as I have said, it has 3 planes which include 11, 12, 13. That is transverse section of the abdomen with the stomach and umbilical vein at the level of cord insertion, and then in the fetal pelvis, which includes the kidneys and then renal pelvis as well. The limb imaging, then pelvis imaging, transverse section of the pelvis, bladder of the fetus, and then both the umbilical arteries have to be documented as I have shown in the previous images. The limb imaging includes femur diaphysis, where we measure the femur length, and 3 bones of the legs, feet, and then normal relation of the both legs and then feet, which includes the ankle, what I said, can exclude the talipes as well. When it comes to the face imaging, 18 to 20 planes are face imaging, and coronal view of the upper lips, nose and nostrils, both orbits and both lenses have documented, and median facial profile, where we actually exclude many of the abnormalities, right, retrognathia, etc., also has to be documented in this 20 plus 2 plane approach. The overview 2 includes the sweep 2, the transverse sweep of the body from the neck to sacrum, 1 vertebra at a time. So this constitutes ISWAG 20 plus 2 planes, which is the standard of care these days. Cervical length assessment is optional in some of the institutes, but at Fernandez Hospital, we do the cervical length, and if cervix is less than 25 millimeters, internal os is closed, then it is called as a short cervix, and there is a role for the vaginal progesterones in these short cervices, which is a marker for the preterm birth. Uterine artery Doppler also is a part of our imaging, mid-trimester imaging. So as I have said, all these 7 steps are very important in conducting this mid-trimester anomaly scan on day-to-day basis, but very important is documentation, and complete report has to be there. Therefore, when we are working in a busy clinics, it is important that we do not miss any plane to any fetus. Therefore, it is important that we maintain a checklist, and this is the anatomic survey checklist given by the same guideline of ISWAG, which is freely downloadable on the internet itself. Coming to the last aspect, that is documentation of the report. Very important, whatever work we do, the anomaly scan definitely is a medico-legal document, and hence electronic and a paper document, and with sufficient required images have to be given to the mother. These days also a motion clip of the fetal heart is also recommended as a part of the important documentation. So what happens because our imaging is all dependent on the fetal position, what happens if we cannot complete this scan on a particular day? We can ask the women to come back again and then complete the scan at the same time. Here is a case scenario, second gravida, first miscarriage, 20 weeks. She came for the target imaging. 4-5 times we tried, but still always the spine was anterior, and then patient refused to wait because she has to catch a flight for the Dubai. Then she came back to deliver with us, and then finally we have to document in this particular things that the imaging is incomplete, and then though rest of the organs are normal, however, due to the fetal position, the details of the face and fetal heart could not be imaged. She had her trip and then stay in the Dubai, and then came back, and she had a spontaneous vaginal birth with us. And you can see what happened to the women. Not that every fetus will go through this, but what saved us in this particular case is that documentation, because our TIFA scan specifically said that due to the fetal position, we could not complete the imaging of the fetal cardia as well as the fetal face. We feel sad for the mother, but from medico-legal point of view, there isn't much that we can do. So to say that, finally, the guidelines are very important, and minimum examination, referral mechanisms has to be in place, and suspected detected abnormalities, we have to guide the couple. And remember, ultrasonography is always operator dependent, and people only see what they are prepared to see. If I am trained for the fetal 4-chamber view imaging, I know. Otherwise, I may not know what else I have to see. That is why the trainings like this are very important. What helps us in day-to-day practice is protocols, proper training, and continued medical education. Thank you very much for the patient listening.